Good evening, everybody. This is Bernardo Cortese from Milano, San Carlo Clinic. I'm really happy to share with all of you and with this panel of experts on DCB, the INCAT Lab Med Alliance UNCAGE episode 1. The topic is the usefulness of a sirolimus-coated balloon solution in complex lesion setting with drug-eluting stent. So I'm really happy to present you Dr. Juan Iglesias from Geneva University Hospital, Switzerland. Dr. Florian Krackhardt. Hello. Dr. Florian Krackhardt from Charité Medical University in Berlin, Germany. And Dr. Kentan Chatlan from Geneva University Hospital again, Switzerland, who will be the chat moderator and will interrupt us in case of questions from the panel. I've been asked to start with an opening session just to define which is the topic we are talking about, and the topic is this one. I hope that you can see clearly my screen. I will go through these next 10 slides telling you which is our philosophy in terms of complex lesion setting management. The complex lesion setting management means not using only drug-eluting stent. We use drug-eluting stents. Drug-eluting stents are good. You can see this is a comparison between two drug-eluting stents that are widely used all over the world, and they are faring quite well with low events. However, which is the long-term, very long-term outcome of drug-eluting stent? It is quite clear that we will have also with the latest generation drug-eluting stent a rate of target vessel failure, which is going there 0.91, 1.5, 2% of events every year. So this is something that is not stopping. Also with the latest generation drug-eluting stent, you can use a polymer, not use a polymer. But the concept here is that after 1 year, if you have put metal, you just have put metal into the patient. You don't have a drug-eluting stent anymore. You have metal that was a drug-eluting stent, drug-eluting prosthesis, but it is not there anymore. And if we go on a very long term, we have to observe that this event rate is not stopping anymore. This is a very long follow-up of the ISAR test 5, and we can see that after 10 years, the rate of adverse events in terms of device-oriented adverse events is 40%. This is quite the same in any lesion setting. In this slide, you can see the very long-term outcome with drug-eluting stent in the STEMI setting. And again, after 1 year, there is no difference between a bare metal stent and latest generation drug-eluting stent. So after 1 year, metal is metal. But this is just a normal lesion setting. What about the complex lesion setting? In a complex lesion setting, the metal is faring worse as what we have seen till now, because we have a rate of events which is double, for example, in the small vessel disease setting, where the events are double than in other cases, and events are even double and even more than double when we put long stents or we pave with stents long segments of our coronary arteries. Here, for example, you can see that the target lesion failure rate is 1.88 as compared to shorter segments treated with drug-eluting stent. And the setting here is not a small vessel disease, but large vessel disease. And again, we can see that if we use drug-eluting stents in a very complex way, for example, in this case, with a very long-term outcome of the Nordic bifurcation study, we put too much metal, 2 stents, mortality is increased. And then what about DAPT duration? DAPT duration is very high, very long with this type of patients. We use even more complex and more potent P2Y12 inhibitors, or we use anticoagulants at low dosages. But here, again, the events in terms of bleeding are there. We have an alternative, which is drug-coated balloon. Drug-coated balloon has had very new data and new devices which came into the market recently. Med Alliance solution DCB is a new concept on drug-coated balloon. This device is eluting sirolimus with a new technology, which is called CAT technology, which has a sort of micro reservoir which are delivered into the vessel wall upon inflation. So you inflate a balloon, 60 seconds, and you deliver the drug there. And what makes the difference with this device is that you will keep the technology, you will keep with this technology the drug there up to 90 days. It's a sort of mimicking of what drug-eluting stents, latest generation drug-eluting stents are doing. So you deliver the drug for the first months. And this is the real novelty regarding this technology in terms of drug delivery. There are a lot of studies which are starting. The device is new on the market, but the company has prepared a very important and intensive clinical program, either in Europe and also in the US, with some FDA studies, ID studies, in order to see if the clinical outcome of this device is as promising as it seems from the first studies. So now I'm done with my first presentation. So I'm leaving the panel to the first case, the first presentation from Dr. Krackhardt, who will tell us his checklist for DCB implantation.
Thank you very much. So I will start with my presentation. So my checklist for drug-coated balloon PCI. Short, a few words for starting with the tips and tricks. Drug-eluting stents are still our workhorse in interventional treatment of coronary artery disease, but perhaps we will change this in the future because drug-coating or eluting balloons represent an alternative therapeutic strategy in a lot of anatomic conditions. Though the slogan was leaving nothing behind, but this is not really true because we leave the drug behind in the vessel wall, as you know. So the effect of drug-coated balloons is based on the fast and homogeneous transfer of antiproliferative drugs into the vessel wall during single balloon inflation by means of a lipophilic matrix without the use of permanent implants. So the rationale, as you already heard, is the new paradigm metal-free PCI to preserve arterial physiological properties, allow positive remodeling, and avoid metallic scapholic complications like inflammation and stent fracture, with the results of higher event rates after stent implantation. So my checklists have three parts. The first part is to find the right patients, the data availability we have, how to improve outcome, the patient selections, which subset of patients can benefit the most, the diabetic patients or patients with high bleeding risk, to lower the risk of stent thrombosis and restenosis and less dependence on debt. As the second part is the physician's perspective, making complex procedures simpler and bifurcations or complex PCIs, extensive optimization in full metal checks scenarios and re-interventions. As you know, sometimes there's a third part, the hospital perspective. You have to look in your country which of these conditions are reimbursed by reimbursing companies. So the most important point is to find the ingredients or to define the ingredients for a successful and effective procedure, the lesion preparation, result evaluation, and then the drug delivery. So the data, we already have seen a lot of data. I will make it short. You have seen it. We have, for the drug-coated balloons, their use is established for in-stent restenosis of both bare metal stents and drug-eluting stents. We have randomized clinical data and a good efficacy and safety profile in de novo small vessel disease and high bleeding risk, but there are other emerging indications with de novo coronary lesions, bifurcation lesions, large vessel disease, acute coronary syndromes, complex PCI and CTOs, and also in certain person groups with comorbidities like diabetes. So these are the recent trials. You know, I'll make it very short. We have a lot of different drug-coated balloons, but now we have the second generation balloons with a sirolimus coated, but the interaction among the doses, formulations, and release kinetics of the drugs used is important. There's no class effect for these balloons. You know, the drug-eluting stent has a slow release. The drug-coated balloon has an intermediate or a very fast release with drug release in the wall. You saw this picture already with new techniques for deliver the drug in the wall. And we have new studies in which studies we perform all the tips and tricks I will show you now. So the most important point is the optimal lesion preparation. Potentially, or in fact, every PCI should aim at using the drug-coated balloon only strategy, which implies a similar approach for every lesion preparation. This requires an optimal angioplasty result, which may be assessed using angiography, functional measurements, or intravascular imaging with drug delivery, then performed with a drug-coated balloon. Stent implantation may be performed for suboptimal results after lesion preparation. For example, if you have a type C dissection, you can use an unacceptable recoil primarily or as a bailout after drug-coated balloon application if necessary, and this should be avoided. So this is the most important picture for optimal lesion preparation with the predilation, and then look for your angiographic results and decide if you can go on with a drug-coated balloon PCI or if you have to change to a drug-eluting stent implantation. So in incomplicated lesions, lesion preparation using a semi or non-compliant balloon with a balloon to artery ratio of 1:1 is recommended. In anticipated difficult balloon delivery, vessel underfilling or potential undersizing, it is reasonable to start with a smaller balloon and reassess vessel size after the use of vasodilators. In the case of expansion failure of a standard semi-compliant balloon, high-pressure non-compliant balloons or cutting or scoring balloons are recommended. So it's easy for optimal lesion preparation is in-stent restenosis, where you can perform an aggressive predilation using high pressors to tackle severe stent underexposition. But also in de novo stenosis, a balloon angioplasty is not feasible. If balloon angioplasty is not feasible or will not produce an adequate result, consider any lesion preparation adjunctive therapy, such as scoring balloon, rod ablation, or shockwave lithotripsy, or prolonged dilatation. These ablative procedures can facilitate optimal balloon angioplasty and subsequent drug administration. So, when the lesion preparation has been performed, an optimal balloon angioplasty result should be confirmed prior to drug-coated balloon delivery. This is important, which consists of the following factors: a fully implanted balloon of the correct size for the vessel wall, lower than 30% residual stenosis, and a good flow, TIMI-flow grade 3 or 4 in the vessel in absence of a flow-limiting dissection. Angiography must exclude delayed contrast clearing from the vessel lumen. According to pre-stent and pre-dep data, type A and B dissections have always been safe to leave after balloon angioplasty, and type C dissection are more open to debate, with some recent data suggesting good medium-term outcomes, but currently any type C or greater dissection should be treated with stent implantation. This is my opinion. In the setting of residual dissections and angiographically limited acute luminal gain after predilation, the use of functional measurement like FFR has been advocated to better define the functional result. So this is the most important picture I told you. You have to have very look for a good and for optimal lesion preparation. So when you achieved an optimal lesion preparation, the drug delivery, the passage of the most recently used predilation balloon may be used as a guide. The presence of very distal lesions, extreme tortuosity, or excessive calcification should all increase the awareness of the possibility of drug-coated balloon delivery failure. The use of a guiding catheter with good support or guide extension, body wire, or something else are all options to aid balloon delivery. So keep the transfer time of the balloon short. Otherwise, you are losing the drug before you reach the lesion. Each drug-coated balloon has specific instructions for use. Particular notice needs to be taken of the maximum transit time in the patient. Do not touch the balloon. Most manufacturers do not recommend reinsertion of the same drug-coated balloon after delivery failure because you have not the same drug on the balloon. The lesion that has undergone lesions preparation plus at least 2 millimeter proximally or distally should be discovered with a drug-coated balloon. So I will finally end my short presentation with these slides from my intervention from the real world registry. As you see here, the reconnaissance of the circ. You have to be aware, or in other words, trust your results. You see here in the after the
Die Playlist TV-Sendungen wird gespielt.
After the procedure, you see only a not so clear result as you're familiar with after a PCI. You see a diffuse picture of the vessel wall, but you have to trust these results. When you see the results here 6 months later, you see the clear result as you see it after a normal PCI with a drug-eluting stent. And be aware, this is a good result also if you see this diffuse pictures from the vessel wall. So thank you very much.
Great, Florian. Very good presentation, very good hints on how we should use a drug-coated balloon. The basic concept, in my opinion, is that we don't have to expect a stent-like result. Obviously, we need to have a not flow-limiting dissection, T-metry flow, okay. But if we expect to have a stent-like result, what do you think? I think that there is a risk of using too many bailout stenting. You have clearly shown that the result, the case that you have presented is very beautiful.
Yes, because many implanters expect a picture like a stent-like picture. And this is, you have to think in mind that after a drug-coated balloon, it's not so clear the picture, but the result is good. And if you have a re-angio 6 months later, you see often you see a late lumen gain or something else. And then you see the clear, the vessels. And this is a learning curve also.
Yeah, you have to believe in this technology, probably starting with simple lesions, type A, B1, and so on. And then you go on more deeply into the more complex lesions. But the message that you gave is very, very important. You don't have to expect a stent-like result. Juan, do you have any comment on this?
Actually, great talk, and thanks for summarizing. I think these are very important topics when discussing the use of DCBs in the treatment of de novo coronary artery lesions. I mean, one point here which is really important, and I mean, we will probably talk a lot about this during this symposium, is to pay a lot of attention to lesion preparation. I agree that we cannot expect a stent-like result at the end. This is not, let's say, the goal of using DCBs, but it's not the reason for not paying a lot of attention, taking your time to prepare the lesion. And you nicely showed that you need to have to use 1-to-1 ratio balloons in order to get at least the minimal recoil, and you should not be, I would say, stressed to use lesion modification devices such as cutting balloons, scoring balloons, which I commonly use now in order to achieve a very good lesion preparation to ensure that you will get the best outcomes at the end. And as you mentioned, I mean, angiography is not everything, and we need to leave dissections. We need to learn how to leave, let's say, suboptimal angiographic results, because this is not what counts at the end. What you nicely showed in this follow-up, for example, is that the remodeling of the vessel, a late lumen enlargement, at the end, the results look very good when you check these patients during coronary angiograms at follow-up. So I think nice points here. I've just questions maybe for you and the audience who may be asking, because it's really important to pay attention to lesion preparation. But as you know, when we use stents, we know that we are somehow undersizing stents and maybe not preparing correctly lesions because we underestimate the level of calcification, for example. What is your daily use or routine use of intracoronary imaging, and would you consider or recommend the use of intracoronary imaging during the learning phase of using these devices?
Florian, I will reply as the first, if you agree. Intracoronary imaging is very important. Okay, so now we are talking about a step forward, which is not a simple lesion, but a complex one. Okay, complex one, calcific lesions, bifurcations. We want to spare metal. Okay, imaging is very important. However, there is one caveat which should be underlined, in my opinion, is that imaging is in this phase differently from drug-eluting stent, where you need to use imaging for initial assessment of the lesion and then final assessment after stenting in order to see if you don't have malapposition or under-expansion. Here, a final assessment with imaging can be somewhat contraindicated. Why? First of all, because you don't put metal, so you don't have the risk of thrombosis. If you have a good angiographic result, we have shown it in several studies. Also, you from Charité with Franz Kleber have shown, and we have shown that if you don't have a large dissection, you don't have any thrombotic issue. Secondly, if you use OCT, for example, in the end, you may propagate and increase the rate of dissection, given that you go with very fast contrast dye injection. And then if you are not experienced with DCB, you may be prone to put more metal if you see those very large dissections after DCB. So very important in the complex lesion setting for lesion assessment, maybe less important for final assessment. This is just a personal opinion.
I fully agree, because you are always tempted to use a drug-eluting stent after the final OCT when you see dissections and you are not, able to cope with the angiographic and the intracoronary imaging aspect. But I fully agree that in the complex settings, when we move from simple de novo lesions, when we go to bifurcations, when we go to CTOs or very diffuse disease, the use of intracoronary imaging may be helpful at least for lesion preparation. That's how I tend to use it in order, as always, to achieve the best preparation as possible.
Okay, Florian, do you have a comment on this?
No, nothing to add. So it's a really good tool, also, especially for the complex lesions. So there you need it, and you have to use it carefully when you're a beginner in this field.
Okay, so I think we should move on for the next presenter, which is Dr. Iglesias, with the first case presentation and discussion. Juan, please.
Thank you, Bernardo, for the kind introduction. And I would like to thank INCAT Lab and MedAlliance for the kind invitation to be present during this symposium and discuss these very important aspects of the use of DCB in daily practice in some complex clinical scenarios. These are my conflicts of interest. So Bernardo has already shown and mentioned this study, but this is important to realize that PCI with the use of long stents in patients with diffuse and long coronary artery disease remains one of the major limitations of percutaneous coronary revascularization, and is associated with a twofold increase in target lesion failure up to 2 years, as shown in this very large patient-level pooled analysis of 5 Korean registries, including more than 9,000 patients. Interestingly, when we look at the landmark analysis, we realize that the increased risk for device-oriented clinical endpoints does not occur only during the first month, but extends between 1 month up to 2 years of follow-up, as nicely shown here. Importantly, long stenting is not only associated with an increased risk of device-oriented clinical outcomes, such as target lesion revascularization or stent thrombosis at 2 years, but also with patient-oriented adverse clinical outcomes with an increased risk of cardiac death at 2 years, as we can see here with a twofold increase in this very large all-comers registry. So when we try to understand the reason why our long drug-eluting stent fail in treating these patients with diffuse lung disease, we should have a look at who are these patients. And we realize that our patients who undergo long stenting are older, are more frequently have more frequently diabetes, chronic kidney disease, previous PCI or CABG, lower ejection fraction. The total stent length is not only longer, but the stent diameter is smaller. And the majority of these patients, or more frequently, these patients have left main disease, complex PCI, calcified lesion, and bifurcation lesion. So we realize that actually when we treat these patients, we are dealing with a higher risk patient and lesion subset. So there are several alternatives or treatment options that have emerged over the last years. And this is a paper published last year by Bernardo, highlighting the use or the potential use of DCBs as standalone therapy or using an hybrid PCI approach combined with drug-eluting stent for the treatment of these complex coronary artery disease and scenarios. This is not, and I'm discussing here hybrid PCI because we already looked at or discussed de novo, the use of DCBs in de novo coronary arteries as a standalone therapy, and this is currently under investigation in the Solution de novo study. So hybrid PCI is not a novel approach. It has already been discussed and published, as you can see here, 10 years ago by Antonio Colombo team in the single center retrospective registry, which included 69 patients. Unfortunately, in this study, because of the use mainly of second generation drug-eluting stent and early generation paclitaxel coated balloons, there were no difference in the composite of all-cause death MI target vessel revascularization at 2 years, and no difference as well in terms of target vessel revascularization. Unfortunately, clinical data and evidence supporting the use of hybrid PCI in daily practice are currently scarce, and probably randomized clinical trials are probably needed in the future to assess the efficacy and the potential benefit of this approach when compared to a conventional drug-eluting stent-based strategy. I would like here to share with you 2 cases to highlight how we can use this technology as part of a hybrid PCI approach in treating patients with complex coronary artery disease. This is a case of a 64-year-old gentleman with hypertension, dyslipidemia, ex-smoker. He has an history of previous TIA and essential thrombocytosis. He complains of a 6-month history of typical exertional chest pain with preservative function on the echocardiogram and an apical septal hypokinesia. This patient underwent coronary angiogram. As you can see here, we found a quite tight mid-LAD stenosis with a faint antegrade flow. The left circumflex was presented with moderate disease on the distal segment of the second marginal, and you can see here the right coronary artery with some diffuse disease. So we went on treating these LAD due to the patient's symptoms after assessing the circumflex on the right coronary artery with a pressure wire, which didn't show any significant disease. And as you can see here, we managed quite easily to cross the lesion with the use of a Fielder Axtior coronary guide wire over a Mambaflex microcatheter. And sorry, I'm coming back here. And subsequently, the lesion was pre-dilated using a Sapphire 2 0 balloon. You can see here the result after balloon angioplasty here in 2 planes, showing a very diffuse disease of the mid to distal LAD and this stenosis at the mid segment. This is the PCI OCT showing diffuse mid to distal LAD disease, and you will see by coming to the proximal segment of the LAD following balloon preparation, you can see already some dissections showing some already a lesion preparation at that point. So went on with a more aggressive lesion preparation using non-compliant balloons to high pressure to the proximal and mid segment. And this is the result following this more aggressive lesion preparation. And we went on by treating the proximal to mid segment with a newer generational zero-emission drug-eluting stent. It was the 30 by 40 millimeter stent, as you can see here, deployed back to the ostium of the LAD. The stent was subsequently post-dilated with a 3,520 and a 4,520 non-compliant balloon. And this is the result after ballooning, after the stenting and post-dilation. And for the distal disease, actually, we decided, this was a 64-year-old gentleman, we decided not to extend stenting beyond the proximal segment. This is how we usually treat our patients, by avoiding stenting beyond the mid-LAD segment. This patient can still have an option for a surgical bypass in the future. So we went on by pre-dilating the lesion with a 2530 non-compliant track balloon, and the use of a 2.5 by 30 solution, a drug-coated balloon. And here you can see the final angiographic result, which was very acceptable from our perspective. And as discussed previously, we went on by doing, because we're in the early phases of our approach using this technology, by using a post-PCI OCT. And as you can see on the first runs here, there was a quite large dissection just at the exit distal edge of the stent, actually, which was left untreated at that time. Some tissue prolapse here in the proximal segment. And this patient actually came back a few days ago for his 1-year follow-up. And you can see here angiographically how the lesion look like now. Very nice result following not only the proximal PCI site, but as well at the DCB site, as you can see here. Very nice result. And the patient is completely angina-free at 1-year follow-up. So this is one of the applications that we actually recommend in these quite young patients with diffuse LAD diseases to use this hybrid approach in order to secure with the stent the proximal site or the proximal segment, and use a DCB or quite long DCBs in the mid to distal to ensure that this patient will keep its vasomotor function of the mid to distal LAD, as well as a potential target for a future bypass graft surgery. And I move on now to the second scenario where we use these devices. This is a 60-year-old gentleman with hypertension, dyslipidemia. He's a current smoker with no relevant past medical history. He came into our cath lab with an history of typical chest pain at rest, with a left bundle branch block on the 12-lead ECG, and a troponin, which was quite unremarkable at admission. The echocardiogram showed a preserved LV function with absence of regional wall motion abnormalities. So in view of the patient's symptoms, went on to offer him a coronary angiogram. And as you can see here, we found a quite tight, severe mid-LAD stenosis, as you can appreciate here in the LAO cranial view on the right panel. Some involvement of the distal left main, which was considered as non-significant. Here you can see the diagonal system with the Medina 111 bifurcation lesion at the level of the first obtuse marginal, and a long diffuse proximal to mid right corneal artery disease, which was actually assessed by a pressure wire, revealing a non-significant disease and left for medical management. So this gentleman underwent as first instance a PCI of his mid-LAD. The lesion was prepared with a 3020 non-compliant balloon at 20 atmospheres, mid and proximal segments. And we went on stenting with an Osira mission 3025 on the mid segment, and proximally with a 3515, so 2 drug-eluting stent proximal to mid LAD. The stents were subsequently post-dilated with a 30 by 20 high pressure non-compliant balloon and a 35 by 20 millimeter proximally. And we went on then treating distally the bifurcation lesion with the diagonal. So this is a 30 by 30 non-compliant balloon at 12 atmospheres. The struts towards the diagonal were open with, here we can see a 2520 non-compliant balloon. And we use a kissing balloon technique with a drug-coated balloon in main and side branches. So this is distal from the stent previously implanted. So this is a solution SLR 3 by 30 in the mid LAD and a 2520 into the diagonal. And we went on by performing a final pot in the proximal LAD with a 35 by 15 non-compliant balloon. And as you can see here, very nice result on the LAD at the end of the procedure, with some, as always, some distal disease on the LAD, which was left untreated. This gentleman, this is the stage procedure to the circumflex OM branch, which was performed a few days after. You can see the results on the LAD is pretty nice. And we went by treating this patient with a provisional stenting bifurcation PCI technique. So the lesion was prepared with a 3/020 into the distal circumflex, subsequently treated with an Osiro 3/026 drug-eluting stent. Then we perform POT with a 3/512 at high pressure. And here on the right panel, you can see the final angiographic result with some plaque shift into the marginal branch. So there are several options to tackle this. You can go back with and just perform POBA, or a kissing balloon with a plain and the regular semi-compliant or non-compliant balloon. In our cases, what we tend to do now is to reopen the stent strut with a non-compliant balloon, high pressure, and perform a kissing balloon inflation using a solution SLR 25 millimeters length into the marginal branch with a non-compliant balloon within the stent, which is inflated here, as you can see. Then final POT with a 358 millimeter stent, and you can see here on the right-hand side a very nice result on this bifurcation lesion with the use of the DCB in the side branch. So, ladies and gentlemen, dear colleagues, these are my conclusions. PCI with drug-eluting stents in patients with long diffuse native coronary artery disease remains a clinical challenge in the current newer generation drug-eluting stent era. And this has been nicely shown by Bernardo Cortese in the first presentation. But this is still associated with an increased risk for long-term stent-related adverse outcomes. Hybrid PCI combining newer generation drug-eluting stent and DCBs has emerged as a novel and promising approach for patients with long diffuse CED to reduce total stent length and minimize the number of stents implanted. This allows as well to restore or keep the vasomotion function of the coronary artery and prevent the artery to be excluded from a potential site of bypass graft in the future. And this potentially may lead to improved clinical outcomes. However, further evidence from large randomized clinical trials is still needed to confirm the safety and efficacy of an hybrid PCI approach with DS and DCB, and to demonstrate the potential superiority of this approach over a conventional DES-based strategy with respect to device-related clinical outcomes for the treatment of patients with long diffuse coronary artery disease. And with that, I would like to thank you for your attention.
Thank you, Juan. Thank you, Juan. You have done a very, very nice presentation, very focalized, and the two cases were so important to me. Why? Because this is the way I think we should act in our complex patients. And I work like you. So you have just shown which is my philosophy in my daily practice. I think that also Florian is believing that this is the way to go, but still there is a lot of work to do with the people outside. I think that we are only 10% or maybe less than 10% of the whole plethora of interventional cardiologists doing this job. I think the future is there. We need, as you finished in the conclusion, we need the clinical data. We need some good studies on the topic, but I think this is the way to go in order to reduce the very long-term events with the drug-eluting stents. This is just as a comment. Yeah, Florian, please.
Yes, this is also my philosophy to treat long diffuse coronary artery diseases and also the bifurcations. It's very interesting. The hybrid approach is we need more data, but we have all the same impressions than patients with a long stents length come back, and we see the restenosis in these patients. And this is the same approach when we are performing a CTO. You only have to treat with a stent the lesion between the proximal and the distal cap, and behind you have performed a POBA, and then all these lengths of the vessel you can treat with a drug-coated balloon. This is the same as you showed in the first case. So I accept this is very, very fine. And also bifurcation, you have two possibilities to treat both vessels with a drug drug-coated balloon or only the side branch. And so mostly I prefer the side branch to treat with a drug-coated balloon and treat the main vessel with a stent. And so it's a lot of intervention cardiologists have a problem to overlap the drug-coated balloon with a drug-eluting stent, and we have data that this is not a problem.
Yeah, totally agree. And I have a question for you, Florian, by the audience. The question is, if you have an isolated left circumflex ostial lesion, do you use a drug-coated balloon as a stand-alone therapy, and which is the problems in treating this type of lesions?
Adenovous stenosis in the proximal circ?
Yeah, just the circ, so it's a sort of Medina 001, just in the ostium of the circ.
So in Germany, we have just a problem with the reimbursement. So we have to look if there are small vessels or is central stenosis. When we decide to treat vessels, proximal lesions, big lesions. So we need a reason to treat it with a drug-coated balloon. And because there's a difference between the costs for a drug-coated balloon and a drug-eluting stent. There's a big difference.
Okay.
But I think that's an important point, Bernardo, because
only the economic point. But I would treat the circ ostium also with a drug-eluting balloon. So I did it already when I perform a left main. You can make a provisional T with a stent in the LID, and you can treat the ostial circ with a drug-coated balloon.
Yeah, the left main, yes. But in this case, if you have an isolated left circumflex disease, it is a pity, in my opinion, to put metal in the left main. So my approach, and this is a very complex lesion setting, my approach would be to prepare the lesion aggressively with a scoring balloon, because the anatomy of the vessel at that part of the left main is different. So we have a lot of elastic fibers. So we need to prepare the lesion correctly, because there is a very, I don't know your experience, but there is a very high risk of recoil of the vessel. So we need to score the lesion properly. And then if we don't dissect too much, if we don't create a large dissection that we don't want to leave in the left main, we can go for a DCB. Otherwise, we have to convert to a drug-eluting stent PCI.
Well, this is completely my approach. That's what I was saying. I mean, these devices actually simplify the way we are treating these 001 Medina bifurcations, which are somehow one of the conundrums that we face in daily practice. And I mean, definitely, I would recommend using these devices in branches like OM branches, diagonals. I mean, there's no way now to treat the main branch with a stent just to treat an ostium of a side branch. And I fully agree with you that the ostium of the circumflex deserves an aggressive lesion preparation with cutting balloons and scoring balloons, because I have exactly the same feeling that you, that the plaque itself is a little bit different, and we should avoid that the maximum of recoil following the DCB therapy.
Yeah. And I have a technical question for you, Juan, from another participant, which is this one. Do you, does two DCBs, solution DCBs, easily fit into a 6 French guiding catheter, or do you have any worry on drug loss during the delivery of the devices?
Well, they fit. I'm using in daily practice, so they fit both in a 6 French guide. I have to say that there's absolutely no friction at all when you use it both. It's always a worry for us to know exactly how much of drug we are leaving behind. I have to say that with these devices and the coating actually that's on the balloon, which keeps the reservoirs with the drug. I don't have so much issues in thinking that we may lose some drug, like for example with paclitaxel eluting balloons or whatever. I use sometimes these balloons. I have to remove sometimes these balloons, and actually the coating is absolutely intact. So I would say I don't have any study to show that. Maybe you will have some more experience, Bernardo, but at least from the cases that I did where the balloon had to come out following this approach, I never seen anything that actually showed that the coating was not intact. So I'm quite confident in using it, and I'm pretty sure that we are delivering the whole drug.
Yeah, I agree with you. There are 2 points, 2 important points with this new generation of devices regarding DCB. The first one is that the technology is not like, you remember the first technologies in paclitaxel, they just put some paclitaxel on the balloon. Okay, not all of them, but some of them were like this. For example, Piccoletto 1 failed as a study because it was just a balloon with some sprayed paclitaxel on it. But this technology is a technology which came 10 years later, 12 years later, and is much more, and I'm much more confident that the drug is there, even if you have some friction. The second point is that deliverability is totally different to most of paclitaxel-coated balloons, which means that you can accommodate 2 solution in the same 6 French guiding catheter. My suggestion is to bring the first balloon distally to the lesion, and then you go with the second one, and then you retrieve the first balloon, and then you go for kissing balloon inflation. It's a small tip and tricks just to spare the drug on it. Okay, I think that for the sake of time, we need to go on, and I'm going to show you a quite provocative case that I selected for this session. This is a 76-year-old man. He's a friend of mine. He's helping me with my foundation in getting some founders for scientific clinical research on DCBs actually. And so he's an important person to me. So he's a hypertensive, dyslipidemic male. He's a sportive man, a 76-year-old, but he goes biking and with atrial fibrillation on treatment with NOAC. So he came at our hospital for a typical angina at moderate efforts, and he had done a positive stress test during one of the COVID periods, and so nobody did take any action. And then he learned about our expertise on DCBs, and he didn't want any or few drug-eluting stents, and so he came to our cath lab for this indication. And so we did a coronarography which showed a mild disease on the RCA. A mild disease on the RCA, and but this is not the topic. And the diffuse disease on the left coronary system involving the ostium of the LAD. So we have a diffuse lesion on the LAD and a diffuse lesion on the circuit. It's quite similar case as the one that Juan just showed us. So what did we do? We decided to treat first the circ, and then in the same setting also the LAD, and then to let the patient come back for a new lesion assessment after a few months, and just a check on what we have done, because we wanted to use a full DCB strategy, and then to treat the RCA, which was a 70% stenosis. So we decided to start with the circ. As I said, we pre-dilated with a semi-confined balloon 2.5, and then we use a solution 2.5 by 40 in the circ, and the result was here. It was pretty good. We didn't want to risk too much in cracking the lesion because there was a bifurcation. So in case of large dissection and the necessity of putting a stent there, it was something that we wanted to avoid. So the result was pretty good, and we stopped there. We did an IFR, which was totally negative for ischemia. So we went on treating the LAD. The lesion was quite calcific, and it was an ostium of the LAD involved. So we decided to use rotablation. We use a 1.75 burr, and then we started quite easy. And then we started using a semi-compliant balloon. It is our first choice to use a semi-compliant just to see how the inflation is going and how is the shape of the balloon at nominal and then a little bit more pressure. And then in case the lesion preparation is not adequate, we go in a stepwise approach with more aggressive balloons. So semi-compliant balloon, 2.5 distally, 3.0 more proximally, 3.0 more proximally, and then 3.0 in the ostium of the LAD. And then we used 3 solution-coated balloons, 2.5 by 40 in the distal part, 2.5 by 40 in the mid part, and a 3.0 by 30 in the proximal part with a distal left main. And this was the result that we obtained. It was a pretty good result, obviously not a stent-like result. We were not sure if to leave this type of lesion unstented, so we did the IFR, and the IFR was negative. So we said, okay, let's stop here, since we have in a 3 or 4 months period of time to recheck again the patient for the RCA, and we see what we have obtained after a few months. So we discharge the patient with the clopidogrel and edoxaban. We don't need dual antiplatelet therapy in elective cases. I have to tell you that in the last 2 or 3 years, we just started using one single antiplatelet, and mostly in patients at high risk of bleeding like this one, who suffered atrial fibrillation. And this is what we found 2 months ago. We found a restenosis in the ostium of the LAD, okay, with a very good result in the circ and very good result in the rest of the LAD. So we did, in this case, the imaging, which was not done previously. And what we found was there was really a non-instant, but a restenosis just at the ostium of the LAD, which is a quite complex lesion setting to treat, with some calcification, but mostly with the restenosis and recoil of the lesion. The left main was okay, and the area was obviously unacceptable, but also the angiography was quite clear in telling us that it was unacceptable. So we were more aggressive in preparing this lesion. In this case, we used non-compliant balloon and then a scoring balloon, 3.0 by 15, and then this was the result. And then we decided to put a drug-eluting stent from the distal part of the left main versus the LAD, 3.0 by 26 at nominal pressure. We did a POT. This was the result after the POT. The result in the circ was not acceptable to us, so we decided to use, in this case, a kissing balloon. After predilatation of the circ, we did a kissing balloon with a normal balloon in the left main versus the LAD, and with a solution 2.75 by 30 in the circ. Then we did a repot with a non-compliant balloon 4.5 by 12. This was the result with a probe of the OCT. The stent was well deployed, no malapposition, no under expansion, no distal or proximal dissection. So this was the segment which had the restenosis due to recoil, which was, in my opinion, not related to the device itself, but just to the lesion type. And then what happened? The patient was discharged the following day. We have a 40-day follow-up, which is quite good because the patient came back after 2 weeks going bicycle. This is a quite provocative case, which is important to me because in this type of patients that you want to recheck with a new angiography, you may decide not to use a stent in a lesion which, where a stent could be implanted. But in case of restenosis after DCB, it is much easier to treat a lesion with a drug-eluting stent, or again, sometimes with another drug-coated balloon. In this case, we thought that the failure was related not to the device itself, but to the lesion itself, which was prepared in the first time with rotablation. 1.75 bore is not a small one. We used a non-compliant balloon, and in this case, we decided to use a scoring balloon and a drug-eluting stent in order to obtain a final result. We decided to use a drug-eluting stent just at that lesion. It was a quite short drug-eluting stent, 26 millimeters, and then this is what we did. So my conclusion, a DCB is an attractive, safe, and efficient alternative to reduce the total amount of metal in multivessel disease and also in a complex lesion, coronary artery lesion setting. These patients usually, in 90% of the cases, are treated with paves of metal everywhere, and this is something that we don't like because we have seen clearly that the outcome is not good in these patients. Like drug-eluting stents, also DCB are not a panacea for all of the lesions, but after lesion preparation, you have to think at another option. If the lesion preparation is adequate, just think at a DCB and put, in the case of complex lesion setting, just stent, a spot stenting where it is needed. And I thank you for your attention.
Thank you, Bernardo. I mean, this is, as you mentioned, a really provocative case. And I mean, this nicely highlights, I mean, two of the main points that we try to make here is that using a DCB as a first approach actually leaves all the options open. I mean, you can still come back, treat with a new DCB, use a drug-eluting stent, or even surgery. I mean, this is not condemning the patient to just a single treatment for the entire life. And I mean, what we should avoid now, I think that we stress a lot about this, is trying to avoid this long stenting, which should not now be happening anymore in our patients. And here you highlighted another point, which is important, is the use of these devices in HBR patients. We still need some data about that, but I mean, from the rationale of it, I mean, makes completely sense. And this is a nice option in patients who cannot tolerate long-term doubt. And I'm seeing that you use as well as I'm doing the solution DCB for a side branch kissing balloon. And I mean, this is a really attractive option. We still need some data to demonstrate this, but it simplifies a lot complex bifurcation PCI procedures, like, for example, in left main or complex LADD1 bifurcation. So Fabian, do you have any comments on this very nice case?
Question to Bernardo for lesion preparation. So, in times where we stented, we learned that the rotablation using a small bore to knocking the calcification, and then we could have a good result with the stent implantation. Do you use bigger bores for preparing when you have a drug-eluting balloon approach?
No, the maximum bore that we use is 1.75 actually. Well, usually we go with a 1.25 or 1.5, but in this case, I wanted to be, because I had some pressure from this patient who didn't want any drug-eluting stent. So, and it was easy for me to follow his suggestions. So this is why I wanted to prepare the lesion correctly. More than 1.25, 1.75, it is not used in our CARA because we go always for radial, unless we go for complex CTO. So we can still use a 7-in-6 French device, but guiding catheter. But no, it is quite rare. What we want to do is to crack the calcium with the effect of the burr, not only in a sort of a shockwave-like activity, which is the traveling of the burr into the lesion. So I think it is enough. You know, there are two philosophies behind the rotablation, and our philosophy is the one of using smaller bars.
This is right, but I believe we need more data for lesion preparation when we have an approach for drug-coated balloon, how to prepare these calcified lesions. Yeah.
We have a lot of cases with the shockwave also, and only DCB. And still, again, we don't have randomized data, but just the experience of a few centers. Yeah, so I think that we need to conclude. Juan, can you give us your conclusion?
Well, thank you, everybody, for this very nice session. And we had great discussions about the use of DCBs in de novo complex coronary artery lesions. Just to wrap up, I think that you mentioned the name Bernardo philosophy. So maybe we need to consider by showing or hearing from these cases that we need maybe to change a little bit the way we are working in daily practice and change our minds. I mean, DCBs are now real options. We have now very sophisticated devices which are really deliverable and will work actually in daily practice. We still need randomized data. And I mean, this is probably something that we should all contribute by giving our colleagues, interventional cardiologists, the evidence to support the use of these devices in daily practice and mostly in complex scenarios. I mean, Bernardo showed that the limitations of the newer generation drug-eluting stents, they are good, they are really good, but we still have some failures. And these failures, unfortunately, accrue over time and there's no real plateau. So we need dedicated approaches. And you nicely showed how this failure of drug-eluting stents are not benign because they increase the risk of device-oriented and even patient-oriented adverse outcomes. So Fabian actually showed us how to his checklist for DCB's procedures and stress on first patient selection, which is an important point. And I think we all started by doing quite simple lesions, but as you have seen from our presentation, now the field of drug-coating balloon is extending to more complex scenarios, and you will hear a lot of that in the near future. And one important point to stress is the importance of optimal lesion preparation. And it's not because you are not using a stent that you should refrain in treating and pre-dilating and preparing the lesion, including with the use of cuttings, coring balloons, or as shown by Bernardo, with the use of rotational atherectomy, which is not a contraindicator to the further use of DCBs. And we tried to show you by our cases that long stenting, unfortunately, doesn't work. And it's not because the devices are bad, it's because the patients are complex. And unfortunately, when you extend the stenting beyond 40 millimeters, actually, this increases by twofold the risk of this device to fail. So we need to provide evidence for the use of DCBs and hybrid PCI approaches to improve these patient outcomes. And with that, I would like to thank InCathLab for this very interesting symposium. I would like to thank MedAlliance for supporting this discussion, and my gratitude to Bernardo Cortese, to Florian Krackhardt, and to Quentin Chatelain for this very nice session. Good evening, everybody.
Thank you, everybody. Good evening.
Good evening.